All right. Once again, we're back with patient assessment. This is part 4 of 5 parts. So we're almost rounding the corner, heading towards the home stretch on chapters 11, 12, and 13. I know this is quite a bit of information, but we've got to go with it, get it, and like I said, I prefer that you view all the segments and then get into the book and bounce through the recordings uh, to get questions or look at some questions that you might have over the recordings. So now we're going to talk about vital signs. These are more than just does the patient have a pulse or is the patient breathing, as we've done earlier. Vital signs are outward signs of what is going on inside the body. Taking vital signs allows you to reassess the patient's mental status because the patient's level of consciousness, LOC, has been assessed during the AVPU scale, then assessed under the D for disabilities, where the GCS is calculated. We're now reassessing again during vital signs. So to obtain vital signs, the first set of vital signs that we are going to gather are known as baseline vital signs and are assessed by using specific procedures. Baseline, we're trying to figure out where we're starting. We're going to get their blood pressure, their pulse, their respirations, their skin presentation, including skin color. Do they have good pink to them? Are they pale? Are they cyanotic? The skin temperature. Are they warm? Are they cool? Are they hot? Are they cold? And the skin condition. Are they dry? Are they moist? Are they clammy? Are they diaphoretic? Skin condition. And we're also going to check their pupil response. Getting a good set of baseline vital signs allow for you to see trends in your patient's condition and help you to respond appropriately to their situation. So when we take a blood pressure, we have 3 types of blood pressure. We could have normotensive. Our patient could be normotensive, hypertensive, or hypotensive. Normotensive would be a normal blood pressure. Hypertensive would be a high blood pressure, and hypotensive would be below recommended normal blood pressure. So our blood pressure is described as systolic over diastolic, or 120 over 80, 120 over 70, 110 over 40, 42, 52. When we take our blood pressures, if we're taking them manually, all of our blood pressure numbers are going to end in even numbers, 0, 2, 4, 6, 8, or 2, 4, 6, 8, and then 0. So the blood pressure is the pressure created when the heart contracts and forces blood into the arteries. The systolic blood pressure is the pressure created when the heart contracts and forces blood into the arteries. The diastolic blood pressure is the pressure remaining in the arteries when the left ventricle of the heart is relaxed and refilling. When you take a patient's blood pressure, you report the systolic pressure first. The diastolic you report second, or 120/80. A rule of thumb estimation for blood pressure is the adult male at rest is 100 plus his age. The adult female, as a rule of thumb, is 90 plus her age to get an estimation of the systolic blood pressure. Hypertension is considered to be a blood pressure greater than 150/90, and actually the doctors are now saying over 80. And hypertension can be caused by exertion, fright, distress, or excitement, or blood loss. I know that sounds funny. How can blood pressure go up with blood loss? But it does that at first and then goes down. Hypotension or low blood pressure could be normal in an elite athlete. So you have to look at your patient, form a general impression, and then when you check their blood pressure, think about your general impression. So we have two ways of measuring blood pressure. We can measure by palpation, or we can measure by auscultation. Auscultation is when we use a stethoscope, when a stethoscope is available. When a stethoscope is used to listen for characteristic sounds. Palpation, on the other hand, is used when the radial pulse can be felt, but we don't have a stethoscope. When we take a palpated blood pressure, we are only going to report the systolic number. When we auscultate, we present both the systolic number over the diastolic. With palpation, we would give the systolic number with a line and then a P underneath it, meaning it was palpated. That's known across the medical field to be able to identify that a palpated blood pressure was taken. So when we take a blood pressure, we need to prepare the patient. So you want to tell them that you're going to take their blood pressure. We're going to position the blood pressure cuff where the bottom side is just above the elbow. We're going to tighten the bulb valve and inflate. When you can no longer hear the brachial pulse, we continue to inflate the cuff roughly 30 millimeters of mercury or higher till we no longer hear the brachial pulse. Then we're going to deflate the cuff and listen for the return of the brachial pulse. And this gives our systolic number. We continue to deflate the blood pressure cuff until the brachial pulse sounds disappear, and that is our diastolic number. Then we're going to record the measurements. And remember, when we're palpating, you will only be able to read the systolic pressure. because we're taking the blood pressure at the pulse point of the radial pulse. So we measure the pulse. The pulse is the pressure wave that occurs as each heartbeat causes a surge in the blood circulating through the arteries. You palpate, feel the pulse when you palpate. If the patient's light-skinned, pulse and skin, color, temperature, and condition can be assessed at the same time. If the radial pulse is strong and bounding, feel the wrist for warm, dry, pink conditions. And if the patient's radial pulse is weak and thready, is the skin cool, clammy, and pale, or is it cyanotic? A weak, thready radial pulse is an indication of hypoperfusion. Next, we want to check for a pulse. We're going to check for the rate, the rhythm, and the quality. The heart beats, the pressure in the arteries caused by those beats can be felt by placing a fingertip over an artery that lies close to the skin. The beats you feel when the artery expands, when blood surges through, is the patient's pulse. We're concerned with three factors. Is there a pulse? What is the rate of the pulse? What is the quality of the pulse? And we count the pulse rates during a 30-second time period and multiply it by 2. And the rhythm of the pulse, we want to make sure that it's a constant rhythm. We don't want to have beat, beat, then a quick pause, beat, beat, short pause, beat, 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 3 beats, and then a long pause. We don't want anything abnormal. We're looking for a steady rhythm of the pulse. Adults, pulse rates. Adults are generally 60 to 100 beats a minute.